Hello, everybody. Good afternoon, good morning, or good evening, wherever you are. Welcome to the Heart Failure Policy Summit, Session 2, Learning from Changemakers, Real-World Successes in Heart Failure. My name is Ed Harding, and I'm the Director of the Heart Failure Policy Network, and it's my pleasure to be your chair today for the first part, followed by my colleague Kirsten Wuddig, who will be chairing the second part of today. Firstly, I'd like to acknowledge our summit sponsors, AstraZeneca and Roche Diagnostics, and say a huge thank you to today's speakers for all providing their time for free. So a brief reminder that we are a multi-stakeholder platform formed in 2015 with the aim of driving political urgency in heart failure. And what you're seeing on the screen frames the offer, the service offer of the Heart Failure Policy Summit to the community of heart failure around the world. So yesterday we were discussing how to position heart failure as a top political priority. In essence, how do we get governments to listen? How do we relate heart failure to some of the big policy themes of the day? What are some of the future directions of travel? And how can we learn from associates who have won the case for change? Today, we'll be turning to the art of the possible. What is it that we can do? And what are the breakthroughs in care innovation and care delivery that we need to learn from, that we need to implement at scale? And also, who should we be working with in advocacy, and who is out there that we can continue to learn from? So here are the questions that we seek to learn from as we go through the summit. So we'll now begin with part one of New Horizons in Heart Failure Diagnosis and Care. So it's my great pleasure to welcome our speakers, Professor Giuseppe Rosano of St George's Hospital NHS Trust, and many other places as well, and the former president of the European Heart Failure Society, Heart Failure Association of the European Society of Cardiology. And he's joined today in conversation with Professor John Teerlink, Director of Heart Failure and Echocardiography, and also the immediate past president of the Heart Failure Society of America. So Professor Rosano, Professor Teerlink, welcome.
Thank you.
As I was mentioning yesterday, we saw an incredible amount of interest from some very high-level decision makers about looking at heart failure, looking at its position in a future and sustainable healthcare system. And they will likely have a very simple question, many of them not coming from heart failure specialist background or being relatively new to it, which is, what is it that we can achieve in heart failure today in 2024? How far have we come in a condition that has been widely understood as being characterized by fatalism, misunderstanding, and ignorance? It'd be fantastic if we could have a quick discussion about some of the biggest themes that would define an expert approach today. And John, perhaps turning to you, thinking about the heart failure preserved ejection fraction and the onset of therapeutic innovation, what has changed and how can we ensure our healthcare systems are ready to cater for this population and ensure early access to a full range of treatment?
Surely, and thank you, Ed, and everybody for the opportunity to participate in this really important policy summit. I think running through this we want to carry through the message from yesterday, which is that awareness of heart failure as an important and essential disease that needs to be addressed by our healthcare systems is really essential and needs to be powering all of these decisions that we go through today. When we look specifically at heart failure with preserved ejection fraction, there's the concept that you can't treat what you don't diagnose. And I think one of the big important things that we've been able to do recently is get more information on how to phenotype these patients, to not say, well, heart failure with preserved ejection fraction is just one big lump of patients. There are very significant differences between the patients who have heart failure with preserved ejection fraction. And as we're learning more and more about how to apply our therapies, both medical, both pharmacologic and device therapies, we will be able to hopefully target these specific phenotypes of heart failure and move the field forward. We have some fantastic improvements in terms of the SGLT2 inhibitors, perhaps the GLP-1 therapies and other agents that we've approached. And I want to make sure Giuseppe has some time to address this as well.
Thank you, John. And I echo what John has just said about the importance of increasing the awareness of heart failure, and especially for preserved ejection fraction, because when you have a disease for which there's no treatment, then it goes undiagnosed. Now that we have one treatment has been clearly proven to be effective, many others that are coming, then of course there will be an increase in the number of patients that will be diagnosed with heart failure with preserved ejection fraction, and therefore that will put some strain on the healthcare systems. And of course, we've observed big improvements in the treatment of heart failure with reduced ejection fraction, and we are starting to see the innovation coming into preserved ejection fraction with a different understanding of the pathophysiology of heart failure with preserved ejection fraction. But also, what we've learned is that the mortality and morbidity of patients with preserved ejection fraction is not just cardiac, is also caused by several comorbidities, and therefore is the interplay between the heart failure with the other comorbidities that is important, and therefore other treatments that may work on both disease or multiple disease, then probably will be the future for patients with heart failure with preserved ejection fraction, also taking into account that most patients that are diagnosed with preserved ejection fraction may have something else like amyloidosis or other diseases. So I think that the main message is that preserved ejection fraction will be the next epidemic. We have treatments, we have started to see treatments coming, but we will probably need to have more and more because it's in order to contain this epidemic.
Thank you so much, Giuseppe. We'll move on to the next point around heart failure, reduced ejection fraction in terms of the rapid titration and plethora of therapeutic options. So following some of these recent landmark trials, such as STRONG-HF, what are the implications for healthcare systems, including the structural changes required, such as, for example, repeat visits to clinics or stronger efforts to monitor titration?
So, if I may start, I mean, it's we've seen the results of this STRONG-HF, but the STRONG-HF is not practically replicable everywhere. I mean, I think that we need to be more creative, and we need to work with what we have in the different healthcare systems, and do not reinvent the wheel. So use whatever we have, and trying to optimize the follow-up of patients. Of course, with telemonitoring will be crucial for the future, because that will enable a remote management of patients with heart failure. But also, what is important is that the role of biomarkers that will allow us to see when patients will start to become unstable. And what is important is that then we'll need to understand what is the maximum dose for the individual patient rather than the target dose, because what we've learned also from STRONG-HF and other studies is that there's not a maximum dose for each therapy, but there is a target dose that is individualized, and therefore use of telemonitoring, telemedicine, and biomarkers in order to optimize our treatments.
Thank you. John, would you like to comment on that?
Yeah, I think Giuseppe really hit up on a very important point. STRONG-HF, a lot of people have emphasized the rapid up titration of the medications, which is clearly important in STRONG-HF. But an other essential component of the trial and of other trials that have tried to address this is the role of heart failure specialists. So it was also randomized heart failure specialists versus general practitioners. It also was randomized of more frequent visits versus less frequent visits. It also randomized BNP monitoring versus not BNP monitoring. So there was a lot to STRONG-HF that I think provided a guidepost for things that we think are important in providing better care for our heart failure with the reduced ejection fraction. Giuseppe already mentioned it earlier, hey, we have these great life-saving therapies for HFrEF, and that's true, but they don't help people if they don't take them. And so we need to get those medications to our patients, and that will require some policy movements in terms of improving infrastructure and support for actually seeing patients, talking to patients, being with patients, and helping them be involved with also advanced practice providers, pharmacists, and other ancillary care providers who can help rapidly up titrate these medications in patients in a very carefully monitored and frequent visit type of setting.
Thank you so much, John. Relating actually back to the previous discussion there around preserved ejection fraction, even though there's a different mechanism, again, that frequency of supervision, that need for deeper supervision, the comorbidity management, all also playing in there. So if I understand both those replies in both questions, really it's about saying we have those therapies, but actually it's about delivery at scale, and it's access to specialism at scale that's every policymaker is going to have to think about their system and how we're going to do this in a sustainable fashion. So clearly a call there for innovation and some local policy efforts. Thank you. Moving on to third question around novel devices. John, if I might turn to you. So for both reduced ejection fraction and preserved ejection fraction, how do we integrate structural cardiology into heart failure management programs? How will health systems regulate devices and ensure access?
Well, I think, this is a crucial problem and an opportunity, and I think we really need to address it as an opportunity. The plethora of devices that have been developed both for HFrEF and HFpEF have taught us not only about how to provide better care for patients, but also a lot about the pathophysiology of heart failure. We're learning more and more in terms of these phenotyping patients to directly give the devices that will directly address whatever abnormality there is. Certainly, the interventions that we've been able to develop for valve disease have been revolutionary in the care of very specific but appropriately selected patients. And so the access issue is going to be very important across all healthcare systems. These tend to be very expensive devices and can also be a bit challenging to put in terms of some of the valve approaches, but can provide some very important benefits to our patients. One of the big issues is also, as you point out, to balance the rapidity of approval and rapidity of access with a full understanding of the safety of these devices. And that's something that's going to be a challenge for regulatory agencies across the world. And there's also these kind of international differences between getting CE mark versus getting an FDA approval. And it results in some very interesting challenges and in some ways inequities in terms of availability of some of these devices. Giuseppe, what do you think?
Yes. No, I fully agree with you. And I think that we have devices that are clearly shown to be effective, and we are underusing them, like CRT and ICD. And we need to probably be more to develop a better network together with our colleagues, electrophysiologists, through the heart failure team, and in order to get the most from CRT and CRT-D and the use of defibrillators. On the other hand, for preserved ejection fraction, we have devices that have been promoted, but they lack a clear evidence of efficacy. And in that respect, it is I echo what you were saying on the fact that we need a clear proof of efficacy, but also an effect of safety, because we've learned in other cases, like for example, coronary interventions in the past, or other interventions that where devices have been put on the market and then they're to be recalled. Regarding structural cardiology, I think that has also to go into the big umbrella of the heart failure team, because at the moment we have interventions that are made by the interventional cardiologists, the cardiac surgeons, and the heart failure specialist is left on the side, whilst these are patients with heart failure and very, very often reduced ejection fraction. So I think that we have different scenarios. One is for the reduced ejection fraction, where we should implement more what we have available. From a regulatory point of view, be more strict and assess better the efficacy, especially in the preserved, and develop more the heart failure team for the use of structural interventional cardiology.
Thank you, Giuseppe, and John, for that fascinating answer. Let's move to our next one on comorbidities and the so-called pre-HF population. You may or may not like that phrase, but in any case, how do we target and apply treatment to those who appear to be at the highest risk, or possibly can be evidenced as on a journey towards structural changes of the heart? How do we implement preventative management and screening in that very large population with a mix of cardiometabolic risk factors? What do we know in 2024?
I think we're learning, we're starting to understand the importance of comorbidities. And this is mostly in patients with preserved ejection fraction, because as I said earlier, we understood now that patients with heart failure and preserved ejection fraction very often have hospitalizations and events that are related to the comorbidity. So by treating the comorbidities early and identifying them early, especially the cardio-renal metabolic continuum, that will be very important. And so treating patients with altered glucose metabolism, treating patients with impaired kidney function, but also patients with CKD or obesity will be crucial. Also, but what we need to also to understand is how to identify amongst those populations, those at increased risk of developing heart failure, and therefore an early diagnosis and probably the AI that will be applied to diagnostic procedures like echocardiography or electrocardiography probably will come into place in order to identify those patients with highest risk to develop heart failure. John?
Yeah, and thanks, Giuseppe. Yeah, I think one of the other aspects that we need to take into account is because these are pre-heart failure conditions, they require massive numbers of patients and data to try to get the information to understand who are the patients who will progress. So this is going to require assistance from our health policy leaders to provide research to do population-based studies that are directed towards our better understanding of what the predictors are. We have a general idea, but if we were to apply every therapy to all of the comorbidities with the idea of preventing heart failure across the whole spectrum of populations, it could be an overwhelming task. So I believe that we need to be able to use the power of our policymakers to support these types of population studies where we can target these populations with the specific comorbidities. And as you say, get a better idea of how to select patients who are likely to progress to heart failure.
Thank you, John. And we'll be touching on some of that I'm sure, in a minute, I'm sure, with Ken Dowles joining us.
Absolutely, yeah.
Research. Looking still at sort of what we can achieve today in precision medicine. So, as you know, in quotes, no longer a therapy of the future, but something that to a degree is here today. What new therapeutic hopes have there been in, for example, particular groups, say amyloidosis, hypertrophic cardiomyopathy? What potential have we got there to change patient outcomes that we didn't have previously?
Well, this is, since we're on a very small call here, I can be comfortable saying this publicly because I'm sure nobody will remember this. But when I did not pay a lot of attention to amyloid, okay, because you'd say you have amyloid and it's sorry and good luck. Now we have therapies that are very directed at amyloid and can slow the progression, and it's very important. So once again, it's this interaction between our understanding of the pathophysiology of the disease, understanding what disease entities are there, and then the development of very specific therapies for it. So on the small molecule range, we have some fantastic new therapies for amyloidosis and hypertrophic cardiomyopathy. But then there are also these emerging genetic therapies, such as CRISPR and other approaches that I think we're going to learn a lot more from. Now, I do want to give a word of caution in as much as heart failure with reduced ejection fraction is a very diverse, heterogeneous disease. And so the likelihood that we're going to have one major breakthrough across the whole pantheon, if you will, of heart failure with reduced ejection fraction or heart failure with preserved ejection fraction is no longer the concept. The concept is to find the specific areas where specific therapies will help those patients and develop them. And it's been a very exciting time. The challenge will be, as we've mentioned all along, the cost and the access to these therapies. Giuseppe?
Yes. No, entirely. And as you said, for reduced ejection fraction, or often that is the end stage of many other cardiovascular diseases, so ischemic heart disease and valvular heart disease, and so on. And but then we have a group of those cardiomyopathies that develop, and they may be single genetic cardiomyopathies, and for that it will be very important to do the genetic screening. So promoting genetic screening when it's possible, when it's needed, that will be important, especially to identify those cardiomyopathies that may benefit from future gene therapies. For the preserved ejection fraction, I think it's important to be more precise in selecting the therapies that may benefit patients with different cluster of comorbidities, as we said earlier. And not only to identify those with amyloidosis or hypertrophic cardiomyopathies that were the Cinderella of our preserved ejection fraction until 2 years ago, and now they are expanding. So I think that in terms of precision medicine, we have a long way to go. And probably for reduced ejection fraction, we'll need to be more precise in identifying those patients with cardiomyopathies that may be genetically identified and probably possibly in the future treated. For the preserved ejection fraction, identify those that are related to, as you said, amyloidosis or hypertrophic cardiomyopathies, or a few other cardiomyopathies that will come in the future, but also in clustering those patients with with preserved ejection fraction, but also different comorbidities that may benefit from treatments that we have today and we can put in place immediately.
Thank you so much, John and Giuseppe, and I think you'll stay with us for a quick Q&A in just a second. So I think we've all worked in heart failure for many years. You know, we can see that there is such an opportunity through timely treatment, guideline-based treatment to reduce hospitalizations, improve quality of life already today. Yet hopefully, so much more to come in future. And turning to that angle, I'm delighted to introduce Seb, who is clinical lead of the Irish National Heart Programme and a professor of cardiology at University College Dublin, to discuss what could be gained through a heart failure research agenda. And actually, just to briefly kick off this discussion, we did ask our audience in advance of the summit what they thought some of the most exciting areas of heart failure research innovation were to keep an eye on in the next 5 years. And actually, as you can see, many of those themes just touched on there by John and Giuseppe are coming out of us, such as HFpEF, precision medicine, so on and so on. And we'll come back to that in a second. But going on to the next slide, just to set the scene there, we've asked Ken McDonald to give a reaction to some of the research priorities we identified in our European Heart Failure Mission, which was launched in October, aiming to identify some of the areas of the greatest opportunity and benefit to society. So without any further introduction, Professor Ken McDonald, thank you so much for joining us, and over to you.
Thank you, Ed. And again, thank you to you and to your organization for the opportunity to speak at this meeting this afternoon. I really enjoyed listening to the comments of John and Giuseppe looking at what is available in 2024 for the management of heart failure. And within their discussions, obviously, was touching on what might happen in the immediate future and indeed further down the line. And to that end, I'd just like to review and put somewhat of a personal perspective on the document that you referred to, Ed, the Heart Failure Mission Research Priorities looking forward. And I think this is a really valuable document and very pertinent to heart failure as it sits today, because it does obviously focus on pathophysiological challenges in heart failure, HFpEF, HFrEF, and the need for further work there, in particular within the HFpEF area. But what impresses me most about this research policy is the holistic approach to heart failure, which is absolutely critical. It touches on the impact of the syndrome on the patient and also on the family, also on the structures of care that we need to put in place so that we can apply the advances that we've heard about and the advances that will surely come in the future. And also harness modern technology. And again, we've heard from John and from Giuseppe about the need to be able to use and leverage the power of AI and e-health in the delivery of optimal heart failure. Now, as you go through that heart failure mission priorities, research priorities, one of the first ones that's touched on is how to detect the undetected heart failure patient. And this seems so simple, yet it's fundamentally critical. There's some great work from the UK came out a couple of years ago about the delay from the onset of symptoms to the diagnosis of heart failure. And this is a blot on our collective copybooks and reflects a lack of structure more than anything else, because we all know what the heart failure syndrome is. It's not like it is, in the majority of times, a difficult diagnosis. It needs to be supported by diagnostics, and therein lies a major threat to the early diagnosis of heart failure. But that, along with the lack of availability of a proper structure of care, and as we delay the diagnosis, and I suppose it's not an active process, but as the diagnosis is delayed, not only do we expose the patient to the impact of a delay in the onset of effective therapy, as been outlined by our co-speakers, but also potentially an inaccurate diagnosis and the placement of a patient on therapy which is not appropriate and not the cause of their symptoms. So that's one area that we need to pay a lot of focus on in the coming years. And again, as we touched on in the discussion to date, the development of an important strategy to prevent heart failure. And again, John in particular mentioned the difficulty that this poses to us, because if you look at the size of the population at risk for heart failure, it's very difficult to deal with a prevention strategy for such a large population. So this approach needs to be layered right away from the bottom of just good healthcare behaviors to risk factor intervention. But we also need to leverage the power of biomarkers, as has been shown by several reports today, the Pontiac study, the Stop HF project, that these biomarkers can underline risk to a higher level than the risk indicators we're taking to date. And this will allow us to focus resources more appropriately on those that are truly at risk, and therefore hopefully prevent. But the interesting angle on the prevention strategy is that even if we fail to prevent, we are diagnosing earlier that patient cohort. And experience locally in our unit is that the average age of diagnosis of heart failure is brought forward from within a prevention cohort. The second priority that has been identified by the European Mission priorities is, how do we halt and how can we further research in halting disease progression? And again, my colleagues have outlined exactly what we need to do there. In HFrEF, it's great that we've made analogies through the years between heart failure and cancer, and usually they've been somewhat depressing analogies about the outlook for patients with heart failure has been the same as the most serious cancer. But here is a more positive analogy that you can draw between cancer and heart failure, is that we're now talking about heart failure remission and heart failure cure. But that's dependent on us using the proven effective therapies. And this is dominantly now in the area of heart failure with reduced ejection fraction. But therein lies a challenge, because we all still know that despite our best efforts over the last years and decades to put in place structures to ensure our patients are being properly treated when they have reduced ejection fraction, those need to be improved. And a multidisciplinary approach to this is clearly important, that we ensure that everyone from the patient and the family right the way through to the heart failure specialist is doing everything in their power to ensure that patients are at least being attempted to be put on these therapies to give them the best chance of hitting those endpoints of indeed remission or cure. The research into heart failure with preserved ejection fraction has already been mentioned, and this is critical. This is lagging behind, obviously. It's almost the Cinderella of what was in general a Cinderella condition. Looking at heart failure preserved ejection fraction is still a challenge, both diagnostically and therapeutically, despite the recent advances in some therapies. And indeed, one of the issues that we need to pay attention for, again, Ed, you touch on this, is that even without specific disease modifying therapies, there's still a lot that we can do for patients with heart failure with preserved ejection fraction in terms of general heart failure care and comorbidity care. But we do in the future need to look at the complex pathophysiology of what is very likely not a uniform condition, but nonetheless should be the focus of attention as we move forward. The third research priority, and one which again has been mentioned, and I think is fascinating and exciting, and hands up, I'm no expert in it, is how do we leverage information technology, and in particular artificial intelligence, to help us look after our patients either at risk for heart failure or with heart failure. And there are many emerging ways of how this tool can be used in this arena, from AI-empowered diagnostics to get around resource difficulties with getting sufficient echocardiography done, either getting the study done or getting reporting on studies. An interesting paper, I think, was in JACC Heart Failure last month, looking at the power of AI-delivered alerts to physicians and nurses during heart failure interactions with patients to ensure that we're addressing specific therapies. The particular paper I'm referring to is to try and ensure we're using MRAs most effectively. But also, I think, coming back to the heart failure preserved ejection fraction story, to aid us with complex data assessment and information assessment to try and get a better handle on specific phenotypes in heart failure and potentially drive more specific therapies for this condition. And the fourth and final priority in the European Mission research priorities was to provide and to look into a more holistic approach to heart failure research and heart failure care in the future. And this is absolutely critical to involve. And again, this is something which I'm happy to report that we're all doing more and more, but we need to pay increasing attention to the impact of the heart failure syndrome on the patient and on the patient's family. And it's just by way of anecdote, I saw somebody just earlier this week, a patient and their wife, and it was interesting. I spent more time with the wife than the patient because of the impact of heart failure on the family of that particular patient. So these need to be front and central in all of our heart research trials and our endpoints, not just simply to focus on changes in ejection fraction, reduction in hospitalization, but on the impact it has on the patient and the patient's family in terms of the totality of their lives. So that's an overview, I think, of the direction of travel in the years ahead. I've no doubt that given the very positive present situation that we're in terms of where we are with capacities to manage heart failure, that if we focus our attention along those lines, that the next 5 to 10 years will bring very significant further improvements for those either with heart failure or at risk for heart failure. But again, it is our duty to continue to put this story in front of the policymakers nationally in our own countries, internationally in fora such as Europe or over in North America, to ensure that the focus of the policymakers and the individuals that drive policy and have funds is directed towards this real threat to health into the future. Thanks, Ed.
Thank you so much, Ken. We see, do we not, around the say Western world, developed world, there are governments willing to spend money in investment funds in many areas of care, dementia, in healthcare, and other areas they consider to be sort of the cutting edge of life sciences, and rightly so. They will benefit human society greatly. Presumably, we should be just as forthright in heart failure in that positioning. I wonder if Giuseppe and John, you have any comment there, building on what we were discussing previously?
Yes, I think it's. There have been several issues that have been touched in the previous talk, and it's. I think that the first point on diagnosed the undiagnosed is very important, and the use of biomarkers is crucial. And I suggest all of you to go and listen to the late-breaking trials at the Heart Failure Association Congress, where Lisa Anderson will be presenting very, very interesting data on biomarkers. And because if we diagnose those patients who are undiagnosed, then we can act early, and we can be in that area between prevention and real disease, and therefore with an early intervention, as Ken said, then we can stabilize patients for long. Now, and that is linked with the other 2 points that you touched about the alter progression of the disease and the heart failure that goes into remission. And given that now we have effective treatments in order to reduce mortality and morbidity, it's important also to focus on other endpoints like quality of life, and therefore the patient-reported outcomes will be important both for patients and carers. So that is important, and often heart failure is seen as a very costly disease, but it's not. If you compare with other diseases that we not even think about, like rheumatoid arthritis, like colitis, ulcerative colitis, where there are treatments that cost 20, 30 times more than the treatment for heart failure without any effect on mortality and morbidity, then we see how important it is to focus and redirect all the resources towards heart failure rather than focusing on other diseases where probably there is a temporary relief, but there's not the same benefit that has been shown in heart failure.
Thank you, Giuseppe. We have a question actually here from one of our co-panelists, is there a role for AI development and use of electronic medical records to identify patients at risk of developing heart failure? I believe the answer is yes, based, for example, Ken, on what you were saying, but I wonder if any of you would like to pick up on that question.
I mean, of course, that is important. And the only problem is that not every country is ready. We have very few countries where we have widespread electronic health records. In other countries, they are virtually inexistent, even if they are within the G7 countries. So I think that is of course, is the future, but it's in order to make it become the future, we need to implement first the electronic medical records in all countries.
I think another important aspect of these approaches, whether it's the AI or the biomarkers or the implantable hemodynamic monitoring, we have this whole range of wonderful monitoring devices. The challenge is that all of these devices are very good at producing a massive influx of data. And the one thing we've learned from all of our intervention trials is that having the data means nothing unless you actually have a person who can act on the data and knows how to act on the data. So at the same time that we're developing these great technologies to do all these types of monitoring and approach it, telemonitoring and things, we need to also find ways to be able to better implement those data that we receive to help the care of our patients. And that's another important part that I think Ken touched upon as well, but we need to, I think, emphasize as well in our future research directions.
But I completely agree with my colleagues, and also I think AI, the question is fascinating because I think the point in time estimate of risk is, I'm not going to say it's straightforward, but it's certainly less complex than tracking how risk changes over time. And that will certainly, in my view, need the power of AI, and then everything else that John has alluded to. Getting a signal that someone's risk is changing is going to still need a human with a proven action at the end of it. So it is a very complex area, but certainly something that we need to devote a lot of attention to, I think.
I guess I'll just I want to emphasize one of the points that Giuseppe said was that, in terms of the importance of heart failure and in relation to its costs for other therapies, where you have dramatic costs for therapies that provide merely symptom relief, yet we hear lots of complaints about how expensive heart failure therapies are, yet those therapies are actually cheaper than those other symptomatic therapies and actually save lives. So there's a lot of education that we need to do in terms of the role of these therapies in heart failure.
Thank you all so much. We will probably stop there. Again, I think a fascinating discussion. Thank you all for that. And I think so many opportunities there, although some of these challenges may sound daunting, such as the use of data. In fact, if we see a new round of cardiovascular strategies and NCD strategies from governments, it would be exactly these mechanisms through which those investments and systems, surely would ideally be built. So that's a mission that the Heart Failure Policy Network was thrilled to continue with your support. So a huge thank you to our first three speakers for that fantastic kickoff to day two. And I'll now hand over to my colleague, Kerstin Buddig, who will continue the discussion on a showcase of heart failure initiatives in terms of system change and advocacy evolution. Thank you very much.
Thank you, Ed. So when we asked people what they are looking to get out of the summit in our pre-event survey that Ed mentioned earlier, many respondents said that they're keen to learn from the experience of others, that they would like to get new ideas about what works and what doesn't, and learn about how we can drive change at a global, national, and local level. And in this next section, we're going to deliver on some of those requests. We're going to hear about leading advocacy initiatives and look at real-world examples of care transformation in heart failure. And first, we'll hear two examples of how to encourage political leadership in heart failure advocacy. And I'm delighted to first welcome Dr. Josien ter Marten. She's cardiologist at the University Medical Center in Groningen in the Netherlands, and she will tell us more about the Dutch Delta plan.
you for the introduction, Kirsten. And the city I live in, Groningen, always remains very difficult to be pronounced in other countries. So I'm honored to say something about the Deltaplan Heart Failure, which is a national initiative in the Netherlands. And this was initiated by the Dutch Heart Foundation, the Netherlands Heart Institute, and the Dutch Cardiovascular Alliance. And if you can go to the next slide. First, we chose the term Deltaplan heart failure because the delta works are the structures in the Netherlands that help us keep the water out. So something that helps us to maintain our country, which is below sea level. So we chose the analogy because for the Deltaplan, because we need to improve and change the way we structure our heart failure care in the Netherlands to make this also sustainable, but also provide the best care that's available for our heart failure patients. But the problem is bigger because we know that only 20% of the Netherlands, the Dutch people, actually know what heart failure is. So there's a lack of societal awareness about heart failure. And this was the background as to why the Deltaplan heart failure was started. We only started a little under a year ago, so it's still very new. And what we're doing now is for almost the week of the 26th of April, we'll have the first National Heart Failure Awareness Week. And we will kick this off with a conference for policymakers, from people who are in politics, but also people from the Department of Health that will come to this conference, and we will give them education about heart failure, but there will also be a panel with policymakers and heart failure cardiologists, but also heart failure nurses, patients, to discuss issues that are ongoing and how we need to address heart failure better, how we can put it on the political agenda, but also on the financing agenda, so we can do more research, improve care, but also make people aware of what heart failure is, to also facilitate early diagnosis and treatment. So that's the one that I've circled, but also in this week, we have over 10 regions in the Netherlands that will also host low regional activities related to heart failure. So this is one of the first steps we've taken. And if you go to the next slide, what we also did over the last year is that we collected ongoing initiatives in the Netherlands. And I know this is all in Dutch, but as you can see on the screen, there are different sections. So some of the initiatives are prevention, some are early recognition, diagnosis, treatment, tertiary care, or palliative care. As you can see, there's sort of a lack of initiatives that are ongoing on the extremes. So that's also something that has been interesting to observe, and that we will develop further in the how we need to change our policy towards heart failure in the Netherlands. So briefly, we've created 4 goals for the Deltaplan heart failure. So we want to increase awareness about heart failure. We want to improve early recognition, optimize heart failure care. And this is something we do in collaboration with an initiative in the Netherlands that's already ongoing and that's funded by the government. That's called the right care in the right place. So there are regions in the Netherlands where they've transferred heart failure to 1.5 line is what we call it. So it's between the GP and the hospital, with heart failure nurses also in the regions or in the villages themselves. So these are initiatives we're currently exploring, and if we will hopefully identify best practices that we can then implement in the Netherlands, and we hope to also convince policymakers, but also our insurances that that's something they need to fund, so to improve care for heart failure patients. And finally, also one of the goals of the Deltaplan heart failure is the initiation of research consortia. But all of this is to create a better sort of environment for heart failure in the Netherlands that includes policy, but also care. And what I like about the Deltaplan heart failure is that we've got a group of people that's really dedicated to this. And those are not only cardiologists, but also people from internal medicine, heart failure nurses, GPs, but also policymakers and people, for instance, from the Heart Foundation. So it's a very diverse group that also helps us to address all issues related to heart failure. So I think, to briefly summarize, we're a very new initiative, but we have very exciting things coming up, and hopefully in a couple months, I'll be able to tell you more whether, especially our policy event, created differences. So thank you.
Thank you so much. I think you're not alone in terms of those really low levels of awareness of HF. I think that's a shared problem in countries across the world. And yeah, it's a fantastic initiative that you're doing, especially the multidisciplinary component. And we're keen to hear the results of that initiative in the coming months.
Yeah,
Thank you.
I'm very excited. Thanks again.
Thanks. And so next we turn to Dr. Marilyn Prasoon, who leads the Heart Failure Patient Council at the Global Heart Hub. And I believe this was the first patient council to be established by GHH, and they've done some fantastic advocacy work over the years. And Marilyn will tell us more about their current projects now. Over to you, Marilyn.
Thank you so much. Yes, the Global Heart Hub is the first global nonprofit alliance of heart failure patient organizations. It's basically serves to establish a voice for those living with heart failure or that are affected by heart failure and cardiovascular disease. Currently, the Global Heart Hub has grown to over 100 patient organizations across 38 countries, all unified to create this global voice. As you stated, Kirsten, the Heart Failure Council was the first patient council established with currently now 46 patient organizations across 26 countries. The priorities are really to increase awareness of heart failure, promote public and healthcare education, and advocate for policy. The focus this year is that first, Heart Failure Awareness Month campaign. We're going to be focusing on heart failure and comorbidities. So working to raise awareness among the public and provide public and patient education. This will be launched in May and then continue throughout the year. Next, we have the International Heart Failure Patient and Caregiver Charter. This has been endorsed by more than 40 patient and clinical organizations. It actually originated out of Canada and was launched 2 years ago in the US and was more recently presented at the European Heart Failure Mission, European Parliament in Brussels. And we're looking to further expand that. Next, we have the Heart Failure, Your Guide to Your Journey. And this is the first international heart failure patient-friendly guide. And so it's based on the American Heart Association and the European Society of Cardiology guidelines and designed in a way that makes it manageable and understandable at a patient and caregiver level for those that are newly diagnosed. So this is an excellent educational tool that can be utilized throughout the various countries. And then finally, the International Heart Failure Patient Perspective Study. This is a collaboration with a survey of 11 countries that are participating in this. And this was a developed survey looking at patient perspectives and of those living with heart failure. And really the goal is to serve to guide future education that is meaningful. So this is an update with regards to some of the activities the Heart Failure Patient Council within the Global Heart Hub are engaged in.
Thank you, Marilyn. And we're really excited to hear about the results of that survey.
Yes,
thank
you.
So now we're going to hear from Dr. Lisa Anderson, if she's joined us already. She's the chair of the British Society for Heart Failure, and she will introduce two really important initiatives, the BSH's 25 and 25 initiative and a new European accreditation program for HF centers that's being developed by the ESC HFA. Welcome, Lisa, and over to you.
Thank you very much, Kirsten. So these two initiatives are among a set of initiatives internationally that are being set up to try and address the epidemic of heart failure. And the major reason that we need to do this now rather than later is that we have a rising prevalence of heart failure with multiple contributors. And in the UK, probably one of the biggest contributors, and also in parts of Western Europe, will be the aging population. And this aging population isn't because life expectancy has increased over recent years. In fact, in the UK, since the financial crash, it has flattened out. It's because of the very large baby boom that peaked in the UK in 1965, after which there was a really big drop in birth rate. But it was such a profound, large bulge in our population that it had subsequent ripple effects through the decade. You see that every 20 years there's a subsequent peak. And because of this, these baby boomers are actually approaching 60 now. In the next 15 to 20 years, they're going to be approaching 80. So that's exactly the time where heart failure is going to present. And unfortunately, whereas now these baby boomers are contributing to a huge tax earning for the country, you can see how rapidly that drops off, and also how rapidly the number of people able to look after these patients is going to drop off as well. So there's the aging population. There's also the general health of the population. Like all other Westernized countries, we have a real problem with obesity, and we're second behind the United States in growing obesity, which is feeding into diabetes, feeding into CKD, and into future heart failure cases. Next slide, please. So this is projected in the UK to be a doubling of heart failure cases in 20 years' time. And this is the map shows the projected expectation of cardiology admissions in 20 years' time, which is exactly doubled as well, mainly driven by heart failure. So if we're not organised now, we're certainly not going to be organised for what's coming towards us. Next slide, please. The European ESC Heart Failure Association programme of iCare-HF is an international accreditation programme for heart failure centres. And what it is trying to do is to make sure that the care facilities for patients are appropriate, both in the community where patients are diagnosed and ambulant patients are looked after in the hospital where acute patients are admitted, but also for advanced heart failure patients in the transplant centre. And it looks at both the human resources, but also the equipment and investigations and interventions that are available at each of those levels to make sure that those are appropriate. And it will test each of the centres that it accredits against the specialist curriculum to make sure that the human resource is adequate, but also against ESD guidelines. And we'll be using GRASP-HF, which is the ESC registry, to look at the data of the accredited centres as they enter to make sure that they're actually delivering the care that they're delivering, but also re-measuring that every 6 months. Next slide, please. So essentially what will happen is there'll be a network of accredited quality care centres set up around Europe, which will then be able to feed into better care, improve services for patients, but also research and policy development networks to raise the profile of heart failure and to make sure that services are set for the future. Next slide, please. 25 and 25 is a UK initiative from the British Society for Heart Failure, and it's different, but it has big similarities. So to address this ongoing tide of heart failure patients coming towards us, there's a long-term strategy to reduce mortality over the next 25 years and to reduce in particular the numbers dying in the first year of diagnosis down from 20 to 15%. Next slide, please. And there's 4 main arms of this. We're going to be looking at detecting patients. So we know that the prevalence of patients doesn't match the registered number of patients. So we need to make sure that all cases are actually registered properly so that they get regular review. We need to measure for early diagnosis of heart failure patients. We have, in the UK, we have the NICE guidelines saying that patients with an NT-proBNP above 2,000 should be seen and diagnosed within 2 weeks, and those between 400 and 2,000 should be seen within 6 weeks. So we need to make sure that patients are being managed in that way. And we also then having been diagnosed, we need to make sure that all of the patients are getting on the 4 pillars of therapy. But the most attractive part of this to me is the prevention arm, because we can't just wait for this huge tide of patients. We have to try and do something before that. So we know the risk factors for heart failure. We know about hypertension, diabetes, CKD. We need to be managing all of those conditions better, ensuring that they're on the appropriate medications so that they don't develop heart failure or develop heart failure later. But also working with policymakers, because we can do things at the national level if we can work with policymakers that will probably have a greater impact than treatment of disease later on. Next slide. From a practical point of view, we've worked with Primis based at Nottingham University to develop a search tool to look for patients and then to measure all of these things like the 2 and 6 week pathway, and also to look for all of the patients at risk for heart failure and make sure that things like hypertension is being treated properly. So in all of the local pilot areas, that will be being measured, and then that will feed into a national dashboard which has been developed by NHS benchmarking. Next slide. With a multi-stakeholder collaboration across the risk factors and across nations and throughout the UK, as you can see on this slide. And final slide, please. And so together, these are 2 different initiatives, both international, because although we're starting with 25 and 25 in the UK, we'll be rolling it out to other countries once we have developed everything. It's all working well enough for international collaboration. Both of these ensure that patients are being managed according to guidelines. Both of these will be looking at data, GRASP-HF or the NHS benchmarking. Both will raise a profile of heart failure, and both, particularly with the prevention inclusion, enable us to talk to policymakers what we can act on causes of heart failure going forward. Thank you very much.
Thank you so much, Lisa. That was really interesting. And I think this doubling of HF cases in the next 20 years that you mentioned, that should really ring the alarm bells for everyone. And I think it's great to have 2 such big programs that are working to deliver optimal care, catch people early, and then also get policymakers on board. Thanks so much. And yeah, as John mentioned earlier, you can't treat what you don't diagnose. And we will now have a closer look at 2 case studies that are working to accelerate diagnosis in community settings. And I'm delighted to welcome back Dr. Rajiv Sankanaran and Nick Harshon-Evans to talk about the case study on community heart and lung screening hubs. Over to you, Rajiv.
Thanks, Kirsten. Thanks, Ed and team, for inviting me to speak again. I've also got Nick with me. So I'm a heart failure cardiologist in Liverpool, and Nick Harshon-Evans is the CEO and founder of the Pumping Marvelous Foundation. So I'll start off explaining regarding this project, and then I'll hand over to Nick, who played a crucial role in developing, supporting the project, and also to give a patient perspective. So I'll be talking about how we can accelerate diagnosis in the community. And after Dr. Anderson's excellent talk, this leads on quite beautifully because the 25 and 25 project is amazing, and this particular project gives us a mechanism how we can detect early and also talk about preventing heart failure. So I'll be talking to you about our one-stop breathlessness diagnostic hub. This involved several partners in setting up. I mentioned the Pumping Marvelous Foundation, but this is being delivered in Everton in the community, which is part of Everton Football Club. This was set up with funding from AstraZeneca, and also involves Us2AI for the AI Echo, Liverpool University Hospitals and NHS Foundation Trust, where I work, Arctic and Lumira DX, and there's also Edgell University who are looking at the research outcomes essentially. Next slide, please. I mean, why Everton Football Club? We know football is a beautiful game. Football does bring communities together. Sport has that beautiful unifying mechanism where people seem to respond. And we thought, why not use that basically to harness and bring about some public health messaging along with this? And as a Liverpool legend, Bill Shankly said, it's much more than football, really. And this can be used for other sports, as John would call it soccer. It could be basketball. It's well applicable across the world, really, if you can use sport as a messaging mechanism to bring communities together. Next slide, please. So what are we looking at? We're looking at breathlessness, which is a significant problem in the community. And these are patients who come to primary care. They end up coming to A&E. About a fifth of admissions are due to breathlessness. And there aren't too many easy diagnostic tests in primary care, and these lead to the delays in detection and management of these conditions, which are COPD and heart failure. So better testing, one-stop testing can increase diagnosis and improve the outcomes. And there's a significant overlap as well between heart failure and COPD. So this leads to a diagnostic and a therapeutic gap. So this contributes to the delays and the misdiagnosis of these conditions. Next slide, please. And in terms of the overlap of COPD and heart failure, we know if they coexist, a COPD can increase the hazard ratio by 1.3 to 1.9 in terms of heart failure, and heart failure can do likewise. And this includes both hospitalizations as well as mortality. Next slide, please. So why did we look at Everton? We said there's a huge football culture in Liverpool and several parts of the UK. But you know, like many cities, Liverpool has pockets of deprivation, and there is a significantly deprived area, both around Goodison Park, which is where Everton Football Club is, but also Anfield. And there's a significant correlation between deprivation levels and heart failure hospitalization. So we wanted to see if this population cohort can be engaged better through the messaging of the football club, so they can attend for essentially public health screening. Next slide, please. So what this is the pathway essentially, and the plan is to screen 1,000 patients over 12 months. So we've just started this project, and so these are people who come via referral from their general practitioners around the area, they may have breathlessness, they may have conditions which can make them prone to having heart failure, and this could be hypertension, diabetes, etc. So, but when they attend, we go through the BEAT questionnaire, which is, are they breathless, are they exhausted, do they have ankle swelling, and if so, we do a point of care NT-proBNP. If there's symptoms or signs to indicate they may need respiratory investigations, that is conducted alongside or instead of a point of care NT-proBNP. And if the NT-proBNP is elevated, we do an AI echo. And as mentioned previously, it's important to have the person at the end of the AI echo, and that is myself and one of my colleagues. So the AI echo is performed by one of the heart failure specialist nurses. I'll be looking at the images as well remotely, so I can action things accordingly, initiate treatment, etc. So it is a one-stop visit, and they can also have AI assisted spirometry, and this is part of the process which is captured in primary care. We use EMIS, so that way they are embedded into the healthcare system, and there is visibility to primary care and general practitioners. Next slide, please. So these are some of the people who've been involved, but it couldn't have been possible without several others. And I can see Binder Figura, who is part of initiating this project right at the outset, as part of this call as well. So just to thank everyone else, and hopefully by next year, I should be, we should be able to update outcomes regarding these 1,000 people we've screened. I'll hand over to Nick to offer his perspectives regarding this project. Thank you.
Thank you very much, Rajiv. So what I want to do is just talk about very, very quickly, as an addition to the excellent talk that Rajiv's just done, about the impact on the patient. So in the UK, heart failure is poorly diagnosed. 79% are diagnosed in hospital, and 40% of those, roughly 40% of those patients have presented at a primary care level whilst being symptomatic. I hope everybody understands the symptoms of heart failure are very challenging and very difficult to live with, extreme levels of fatigue and extreme levels of breathlessness. So the sooner we can diagnose, the better. We know the more efficient the diagnosis, the better the opportunity to get specialists, and the outcomes are for patients in the system completely increased a lot better, both from a quality of life, cost and mortality angle. The system we've developed at the People Place Everton in the community is essentially just about gluing together the existing evidence-based modules. So it's actually nothing too new. The newness is gluing it all together. So I put this to you. Imagine being able to diagnose heart failure and initialize treatment within 30 minutes, depending on whether further tests and investigations are needed. And I think that is a great challenge for us all. Thank you.
Thank you so much for such a fantastic case study. We had one question from the audience to Rajiv. What is the cutoff for NT-proBNP? Slightly technical question.
Yeah, so we use the cutoff which is applied by NICE guidelines in the UK, which is 400 nanograms per liter, above 400 nanograms per liter.
Okay, great. Thank you. Okay, thanks, Nick and Rajiv, and I hope you stay for the Q&A in case people have more questions. We're now going to hear from Leanne Macklin. She's National Heart Disease Improvement Coordinator at the Scottish Government, and she's leading the Opera HF Care Pathway in Scotland, which is a fantastic example of a modular pathway that can be adapted to different settings and different countries. And the pathway is currently piloted in various countries across the world, including in Spain. And this is a pre-record, so we'll hope this will all work smoothly.
Hello, everyone. My name is Leanne Macklin. I am a Senior Cardiology Advanced Nurse Practitioner working within NHS Forth Valley in Scotland, and I'm also the National Heart Disease Improvement Coordinator for the Scottish Government. Thank you to the Heart Failure Policy Network for inviting me along to speak today. We're going to speak to you about a large clinical trial that we undertook in Glasgow during the second and third wave of the COVID-19 pandemic. The trial was called Optimised Pathway for Early Identification of Heart Failure in the Community, otherwise known as OPERA. My disclosures. So, we know that heart failure carries a high mortality risk, and it is akin to most common cancers. So if we look here on the left, in men, the most common cancers are prostate, lung, colorectal and bladder, and we can see that heart failure is right in amongst that. On the right hand side, if we look at women, the most common cancers in women are breast cancer, lung cancer, colorectal cancer and ovarian cancer, and again heart failure is in amongst that. In Scotland, the Scottish Atlas of Healthcare Variation showed in discharge increased by 35.2% from 266 per 100,000 of the population in 2012-2013 to 360 in 2021-2022. Heart failure is increasing year on year, and we know that that will continue due to an ageing population and also from people surviving other types of heart disease. For OPERA, our main objectives were to try and identify people early that may have heart failure within primary care. So what did we want to do? We created a deployable and scalable digital platform for heart failure diagnosis and for the initiation of treatment. And we wanted to prospectively validate artificial intelligence analysis of echocardiogram images in a pragmatic cohort. And the reason for that was, for the AI models, was to identify those at highest risk of having heart failure and to support clinical triage and prioritization of those at highest risk. If we think about a full stack echocardiogram, it is labour intensive, it requires very skilled clinicians to carry out these tasks, and it takes around 45 minutes per patient. The thought process behind AI echocardiogram was to try and see if we could cut that time down to establish if people had heart failure or not, and to test the AI against highly skilled full stack echocardiogram. So here is what the OPRA pathway looked like. Patients are referred in from primary care, from their GP or ANPs, primary care clinicians, with signs and symptoms of heart failure, and they undertake a cardiac biomarker known as NT-proBNP in the community, and if that's elevated, these patients are referred into secondary care. Within secondary care, a senior decision maker, a clinical decision maker, undertakes a vetting process known as active clinical referral triage, ACRT, and this allows for patients to be prioritised based on the levels of their cardiac biomarkers and also their signs and symptoms. We can also take into consideration any past medical history, etc. It also allows us to remove people that shouldn't be on the heart failure pathway and signpost them to the correct pathway or advice back to their GP. The patients were then invited up to the one-stop shop for OPRA. And when they arrived, they were asked if they wanted to be part of the research. Now, this was a real-time waiting list within Glasgow. And Glasgow in Scotland is the highest health board with around 1.2 million people. This was a real-time waiting list which had obviously grown as due to the COVID pandemic. There was backlogs, and patients were invited up. If they didn't want to be part of the research question being the AI echo, then they still had everything else done for them on the day. They would undertake some patient-reported outcomes, and if required, a lot of these patients are frail or elderly. They would be supported either by their carers that were with them or by our healthcare support workers or nurses on the floor to undertake them. They then had a height, weight, blood pressure, oxygen levels carried out, an ECG and an echocardiogram. And if they were part of the research question, they would have the full stack echo and the artificial intelligence, a handheld echocardiogram at that point. They were then reviewed by a cardiology ANP at this point, who looked at the results of the echocardiogram, of the ECG, the blood pressure, etc. They took a focused clinical history and examination of the patient, and all of this information was populated into a specially designed digital platform to allow for virtual review and outcome by a cardiologist. If the patient required treatment on the day, the ANP that reviewed them would initiate that treatment and write to the GP on that day for the initial treatment being started. All of the information of everything gathered from that day was populated onto the digital platform to allow the cardiologist to remotely review the patients. This is what the patient-centric app looks like. So if we look at the first 1 year appointment, we can see that gives us what the patient reported, so EQ5D, PHQ4 and KCCQ12, and they're all populated there. If we look at the middle box, the senior clinical decision maker who's going to be outcoming remotely can look at the patient information, background information, what symptoms they were reporting, what would their ECG look like, their echocardiogram, their blood results, any past medical history and any current medical therapy, and their clinical examination and their social factors. They can then make a outcome and a robust management and treatment plan for these patients remotely and send that to the GPs. This is where we undertook the clinical trial. It was within the NHS Louisa Jordan, which was a makeshift field hospital for COVID-19. Unfortunately, in Glasgow, we didn't require to use that for COVID patients. However, we relished the opportunity to use the facilities in order to undertake this clinical trial and also see patients that were on a real-time waiting list for a diagnosis of heart failure. Prior to working within the NHS Louisa Jordan, the only other time I had been at the SECC, it was for concerts, Beyonce, etc. So it was quite a shift to then working in it as a field hospital. The impact of Opera has been substantial. It reduced the waiting list, by 30 to 50%, because we were able to remove inappropriate referrals from the waiting list at the point of ACRT, the active clinical referral triage. Increased capacity for cardiologist face-to-face clinics, because not all of these patients that attended Opera had to come back and see a cardiologist. They could be managed remotely. Increased productivity, as cardiologists can review twice as many patients virtually as they can do if they were to see them face-to-face in clinic. The reduction in echo waiting times for Glasgow, NHS Greater Glasgow and Clyde, reduced from 12 months to around 6 weeks. And it was a faster diagnosis. It takes around 3 days, maximum of a week, to get a result to the primary care team. As part of the Opera work, the University of Glasgow, and thank you to Professor Olivia Wu and Dr. Nicola McMeekin, who's allowed me to share this information with you, we undertook a health economic evaluation. And basically, the top line of this is that Opera can support NHS recovery of the elective backlog, and it can also reduce the ambulatory care pressures through healthcare efficiencies and the early optimisation for the treatment of heart failure patients. We know that if we get access to heart failure patients earlier in the trajectory, then we improve their outcomes and their quality of life. Unfortunately, around 80% of patients with heart failure are given their first diagnosis whilst in hospital as an unscheduled admission. So the idea behind Opera is to flip unscheduled care on its head and get to these patients earlier in order to improve their outcome and prognosis. There was an 89% reduction in waiting times for patients with suspected heart failure as a result of Opera. 9 times more patients can be screened every year because Opera frees up consultant time in the diagnosis part and management of the heart failure patients, and around 4,700 cost per QALY gained. So this shows that it's highly cost-effective solution, and cost-effectiveness estimates are within what NICE considers acceptable use of NHS resources. So Opera will result in an overall increase in medicine spend. However, this will be counteracted with significant improvements in healthcare efficiencies and optimisation of care, therefore reducing the amount of unplanned hospitalisations and also improving health outcomes. So the clinical service learnings, what did we learn from Opera? There's pathway benefits. It is a blueprint for NHS remobilisation and recovery and redesign. As we know, there is now huge backlogs across all specialties, and cardiology is not alone in this. The patient experience, we engage with patients and held lived experience. Within our workforce, it really inspired people to do more, take on more advanced training. Lots of people within Opera have since went on and changed their job, advanced within their career, and also improved cross-functional working and professional development. We've now funded it in Scotland into routine care within NHS Greater Glasgow and Clyde, and also NHS Forth Valley. I want to say a special thank you to the Opera team, who were incredible throughout all of this. This is just a few. There was many, many more nurses, cardiac physiologists, etc. involved in the delivery of this, and it was a fantastic clinical trial in a real-time population, which reduced the waiting times substantially during what was a very difficult time for us all. Thank you so much for listening to me today. and I'm sure if there's any questions, the Heart Failure Policy Network will be happy to pass them on to me, and I'll do my best to answer where possible.
Thanks a lot to Leanne for this presentation, and we'll pass those questions on if there are any for Leanne. So we will now move into the final section of our session today and turn towards a really important topic. And I think it's one of the biggest levers that we can pull to better diagnose and manage heart failure. And that's heart failure specialist nursing. And as part of our European heart failure mission, we've developed a call to action on specialist nursing to elevate the role at the European level. And please have a look on our website and use the call to action. But for now, I'm delighted to hand over to Professor Izabela Uchmanovic. She's the president of the Association of Cardiovascular Nursing and Allied Professions, and she will moderate a roundtable discussion on this topic and help us find out how we can boost this important role. Welcome, Izabela.
Welcome, everyone. Thank you for this nice introduction. So we will have a short discussion on heart failure specialist nursing. And I'm joined today by Dr. Marilyn Prasun, who is a past president of American Association of Heart Failure Nurses, chair of Heart Failure Patient Council, Global Heart Hub, and endowed professor in Mennonite College of Nursing, Illinois State University. And I'm also joined by Rodolfo Pike, who is a nurse practitioner and congestive heart failure clinic, Eastern Health Canada. And I'm really glad that we can talk about the role of heart failure nurse specialists, because I think we are all aware that the nurses have the pivotal role to the delivery of optimal heart failure care for many reasons. Firstly, they provide continuous comprehensive management of heart failure patients, which is crucial given the chronic nature of this condition. And through patient education, they empower also individuals with heart failure to understand their condition, adhere to the treatment plans, and also recognize the early signs of exacerbation, therefore reducing the number of hospital admissions. Moreover, heart failure specialist nurses serve also as the key, and I like this word, in the multidisciplinary teams, ensuring cohesive care strategies that align with the best practices and patient-centered goals. But I just wanted to introduce you in the topic, and now I have a question to Marilyn, who has a great experience and have done a lot of research on heart failure nurses over the years, and in particular in terms of value of implementing a certification for heart failure nurses. Therefore, can you tell us a bit more about this and how heart failure nurse certification can drive better heart failure care?
Well, thank you so much, Izabela. I am thrilled for this opportunity to share some information. One of the more recent studies, the American Association of Heart Failure Nurses offers a certification exam for nurses, clinical nurses practicing. And, you know, there are requirements with regards to the amount of time that you've worked in the area, but it is a certification to really demonstrate your knowledge and understanding of current evidence. This test that we offer is updated regularly as new evidence comes forward and is based on the current American Heart Association guidelines. But in 2018, my colleagues and I looked at a study and examining nurses' decision-making in heart failure management based on certification. So we had over 600 nurses participate in this study. A little over 29% were certified in heart failure. 35% were certified in a different area. And then about 35.9% were not certified. And so we looked at comparing that, and what we found was heart failure nurses that were certified in heart failure had a significant increase in clinical scores. We provided vignettes, validated vignettes in this study, and their score was significantly higher demonstrating higher evidence-based decision-making. And ultimately, what we were able to conclude was that heart failure certified nurses being certified was associated with decisions reflecting delivery of higher quality care. So there is value in the importance of education and actually focused education in heart failure. The more nurses, and again, as you said, being in a key position, that we can ensure that they have an understanding and knowledge and can act on that knowledge, ultimately can improve patient outcomes.
Okay, thank you for this comment. And by summarizing what you just said, it comes that the better education of heart failure nurses and trying to make like a specialization for heart failure nurses will bring the better care for a patient and better outcomes.
Absolutely.
Okay, so I thank you for this. And I have a question also to Rodolfo. Because Rodolfo, upskilling nurses to provide optimal care for heart failure patients is an important topic across the globe. You have been working to bring together nurses at the global level. Could you tell us more about this initiative and what challenges it seeks to address?
All right, thank you, Isabella, and thank to the Heart Failure Policy Network for the opportunity to actually come together in this collective forum today to speak. Getting back to Marilyn's point, it's very important. We all know, as was identified through the European Society of Cardiology, the looming healthcare crisis, in particular facing the nursing groups across the globe. I don't think it's unique to one country, but it's a global shortage. And how is it that we're going to get that much needed workforce to get in these specialized areas? That's challenge number one. Challenge number two is once we get that workforce and get them, how is it that we actually can upskill those nurses to be the highest quality and work most efficiently within those programs without the appropriate education? A lot of times these practices, they can actually vary from province to province or from one geographic region of your country to another. So how is it that we can actually develop global policies that can help guide that framework for bringing nurses or allied health professionals into the whole heart failure world? So take that one step further, and just on the initiative that I started working at over the last year, had the opportunity to meet a lot of nurse leaders globally through a number of different venues and look to see if there was an actual interest in developing a global heart failure nursing and allied health network that we can sort of come together from key organizations to look at, see if we can actually share best practices for knowledge sharing and exchange, research findings, and also are there innovations in healthcare that are taking place at a local level, at a national level within countries, so that we can actually share, bring back to our own organizations, and then disseminate through to our members. We all share a lot of the same struggles in managing our heart failure patients. How is it that we can actually utilize some of the best practices that are already established across the globe? May not necessarily be written in research articles, but they're working quite well within the organizations where they've been implemented. And how is it that we can build on that capacity? Also, if we bring a number of nurses from across the globe from organizations that are heavily vetted in heart failure management, then is there capacity for us to also advocate for the nursing profession, also within the allied health profession, of what is needed on a standards level to actually improve that process for upskilling nurses as we move forward and we try to deal with the looming healthcare crisis. So I think it all fits in that we have to look at the healthcare crisis. We have to look at how is it that we're going to certify, but also I think the time is now for us to start looking at things from a global perspective and how can we use that collective effort to improve those outcomes for people with heart failure from pre-diagnosis, diagnosis, management, and also end-of-life care. Thank you.
Yeah, I think it was a very good comment, and it came to my mind that you said something very important. You said that we need like a global initiative. I wrote it down because exactly what you have pointed out, it's that we write research paper. We know what we need to do. We know what is better. We know that we need the nursing for the certification for heart failure nurses. We've just heard about the initiative from American Heart Association. Also, European Society of Cardiology is coming with heart failure nurse curricula, but we cannot meet together at the one point, right? To do something globally and to perform something that will work for everyone, like at the global level, because we also struggle with the different education programs among Europe and among the world. So I think it was a very good point that maybe it's the time to work together, and this initiative today, and also the call from call to action on specialist nursing that was developed by the Heart Failure Policy Network. I think it's something what we need. And we need this meetings like this one, that we can meet and talk together, and then maybe because of this we will come to the correct point, and we will do something globally, not only on the level of different associations or countries. So we are a little bit over time, so I don't want to prolong this meeting, but I think it's a main issue that we just raised, that we have to work together globally, not on the, as I said, within the association level or country level. So I think it's a main point from our meeting today. I can see that Rodolfo would like to say something, so please.
Yeah, if I can just sort of, we have actually had an inaugural meeting in February of this year, and it was great to have that collective effort around the table, just establishing a terms of reference and what the structure and the process is going to be for this community, this organization going forward. We're not looking to create something new. We're looking to establish the collective effort of everybody that's already established in the heart failure world globally, and how is it that we can monopolize on that to move that agenda forward.
Okay, thank you for this comment, and actually thank you all, and thank you everyone for joining us. And what can I say? I can say that we would like to see everyone next year at the Heart Failure Policy Network Summit.
Thanks so much, Isabella, Marilyn, and Rodolfo. And I feel like we could almost end on this word, working together globally, but we do have a Q&A section now. So if you would like to still stay on, we've collected a couple of questions, and I was wondering if Nick is still on the line. Nick, are you still here? Oh, yeah, great. So yeah, actually, I tried to pitch your Everton football example to at the German Heart Failure Roundtable, where I was a couple of weeks ago. But I was just wondering, for those seeking to emulate that example with the Liverpool Football Club, what would you recommend in terms of making an approach and building a relationship to the relevant stakeholders?
I don't know whether Rajiv's still on the. I think Rajiv still is.
Please join us as well. Yeah,
I'm still here, but I can't seem to unmute. Can you hear me?
Yes.
Yeah. Oh, yeah. Hi.
Can we spotlight Rajiv? Yeah. Great.
Yeah, I think it's about identifying the problem first of all. So we said the reason we identified the area and the football club, there is an existing problem, in areas of deprivation, for example. But this is not unique to, say, Everton. There are similar examples across the world, isn't it? We know that heart failure takes a while to get diagnosed before these patients end up in the hospital. But it's about trying to engage communities who may not necessarily present to primary care, and using that messaging. So I think it's about finding like-minded individuals, speaking to the football club, having a clinician. So Everton's a unique example where you have a GP who's based there as well. So it's having the GPs or primary care practitioners as a part of it as well, because it's not just a one-stop issue. Once you do a diagnosis, there is treatment that needs to be initiated. There's a mental health impact to that as well. So there's a whole thing that needs to be looked at. So it's about embedding all those, but it's a process. And if you get a few like-minded individuals together, I think it's very possible.
Great,
and also, I think football clubs in the UK are very community-based, just like rugby union and rugby league clubs and cricket clubs, the big sporting venues. And they very much want to be seen to be helping out their fans, their supporters. And I think that's the line that needs to be taken, where I think with the Premier League, there's so much money that is in the Premier League, like other leagues around Europe, and certainly in the NFL in America and the US, that they want to be seen to be doing some good things with that money and seen with that outreach. And one of the things that really sparkles for me is that you think so many times about how you can engage people, and you fail a lot of the time because you're learning all the time. But actually, when you have a brand like Everton, or let's say just around the corner, Liverpool Football Club, it's their home, it's their tribe, it's who they are, and there's a lot of trust there. So naturally, you can use that to your advantage. Everton and Liverpool just happen to be in very, very deprived areas of Liverpool, where we know that deprivation is linked to worse outcomes in heart failure and cardiovascular disease as a whole. So, and as Rajiv said, putting like-minded individuals in the room who believe in what you believe in is a big thing as well.
Right, thank you. We had another question from the audience. Why not introduce a targeted screening program for patients at risk? So we know that screening programs are the norm for many forms of cancer and other diseases. Why can't we do the same in heart failure? Would anyone like to answer that question or comment on that?
Yeah,
Yes.
I think Rajiv is probably in a really good position to relate that to what we were talking about yesterday, which is the mass screening of people for cardiovascular diseases and heart failure, and then the more targeted screening of Everton. So I'll just hand over to Rajiv. Sorry for putting you on the spot.
No, it's a good point, and I was making this point earlier as well about Lisa, Dr. Anderson's talk about 25 and 25. So it's about achieving those and detecting the undetected, and about preventing these conditions. So when we're talking about screening, it's important that we also look at, as Ed mentioned, maybe the pre-heart failure conditions. Hypertension. There's 80% of people who have heart failure have pre-existing hypertension. So if we can detect that, manage that better, not only are we detecting heart failure, we're also preventing heart failure. So it's important that if it's done, and if it's done at scale, what happens thereafter? Once a diagnosis is made, what happens thereafter is as important as not making the diagnosis as well. So it needs to be thought through as to how that's followed up as well. But it's about detecting the stage A, stage B heart failure, based on the American classification of heart failure that we know, because the bulk of the problem we are doing at the dealing with at the moment is in the hospital, isn't it? If we can divert that focus to the community, prevent and detect earlier, these people can be managed better, their outcomes will be better. The 25 and 25 and the mortality reduction, that's one important mechanism of achieving that. But it needs to be thought through as to what happens, and we have to include primary care, not leave them out of that. So they have to be part of this as well, because they will be managing these patients in the community as well thereafter.
Great, thank you. Dr. Anderson, would you like to comment on that as well?
I agree with all of those things, but I think we need to be also even more ambitious. And because heart failure, by the time somebody is even early detection, it's too late. They've already developed it. And in fact, even hypertension is too late. We have to get really downstream. We know what's contributing to this. We know that social inequality poverty, lack of social mobility, all of these things, and a very sort of westernized, poor quality diet. This is all leading to the problem. And I think if we can work better, raise the issue more with policymakers and politicians, when we need more sort of national programs to address this. So things like the smoking ban in the UK has had a bigger impact than any single doctor or any health service. And I think we really need to be thinking more like that for the future.
Thank you. And maybe a question for the nurse panel. We had a question from the audience. How can we ensure that heart failure patients are receiving adequate quality of life care and support? How can we integrate that into routine care, and how can we evaluate it?
I'll go ahead and respond, and I'm sure Olaf would also want to weigh in on this, but I think that the more education we can provide nurses, because we talk about specialty heart failure and nursing care, but heart failure occurs across the continuum. So when we think about nursing, there may be an extended care facility where heart failure patients reside. There may be an in-home situation. So although we talk about specialty heart failure education, and I guess I'm thinking real global here, but I think we really have to zero in, ensure that across the continuum, nurses are educated, and then those that work in the specialty area have additional, more intense education. So I think through education and raising the bar and creating opportunities where nurses can respond. For example, if there is a question about medications, that they're in a position where they can thoroughly vet that and work with resources that are available to seek to ensure that they address that, because they really are in a key position. And unfortunately, and I can speak from the perspective of being within the United States, there are a number of heart failure specialty programs. However, when you look at the overall population, I live in Illinois, which is in the middle of the United States, in a large rural area. Patients have to travel a long time to get to a specialty clinic. So I think really arming people there on the front lines can have a powerful impact on outcomes.
I agree on this comment 100%, because I think if we have better educated heart failure nurse specialists, they will be taking better care of patients. They will be better prepared also to educate patients. So then, therefore, we will have better patient outcomes.
And I think if we take this one step further, we go back to even the basic nursing education programs. Generally, I'm called on to go present at the university level for the baccalaureate program, and there's 1 hour of education for heart failure, considering the impact that it has on our healthcare systems, the impact that it has on mortality once you're diagnosed with heart failure, and also all the risk factors. And it's, not so much that it's not deserving, but such limited time in that whole basic program. Take that one step further, then we have all the continuity of care across the lifespan. So people in the community, community health nurses, they're not well versed in heart failure management or care, or even what to look for. And I also think we need to go back to putting some, not so much ownership, but putting it back with the patient, that start identifying your symptoms, ask for those testing. No, it's not normal to be breathless. Don't wait 5 years going back and forth. Another puffer, another treatment, another test, another x-ray to, it's not normal to be breathless, and making that awareness upfront that this could be heart failure. So I think education programs, both from a basic education level for nursing all the way through, and including the patients to ask their primary care providers or their nursing group that they're involved with, is this heart failure?
Mm-hmm. So also emphasizing self-care and patient empowerment. Okay, great. Well, thanks so much. We've slightly overrun, but thanks so much for attending the second and final session of the Heart Failure Policy Summit today. We hope the discussion has been useful, and we really appreciate your engagement before and during the summit. And I really want to thank all speakers for volunteering their time for free and sharing such valuable insights and inspirations into how we can improve heart failure care and drive policy action. The recordings of both sessions of this year's summit will be made available online, so you can look at our webpage early next week and watch back to the recordings. And if you have any questions about our work or would be interested in becoming a member, learn more about the European Heart Failure Mission, please do get in touch with us via email. Thank you.